Welcome, everyone. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center in Des Moines and founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And our topic tonight is how to optimize your mental health. And our guest is my friend and colleague, Katherine Gillmor. Katherine is a licensed mental health counselor, not a social worker, a mental health counselor.
That's right. Yeah.
And she's a psychometrist.
That's correct.
Yeah. Yes. So we're going to learn what a psychometrist is. It's not someone who examines your eyes.
No, not at all. Don't ask me.
But our topic is really how to optimize mental health. And Katherine is a member of our care team at the MercyOne Richard Deming Cancer Center, where she does counseling for our patients. So let's get to know you first as a person rather than, and then we'll get to know you as a professional and learn what you're doing. And then we'll talk about optimizing mental health.
Sure.
So where are you from originally, Katherine?
Yeah, I'm from Northeast Ohio, right between like Cleveland and Akron area.
So is that like near one of the Great Lakes? Are you
Lake Erie?
Lake Erie.
Yeah, we got all that lake effect snow.
How far from your house would it be to get to the lake?
Hour?
Okay.
Or so, depending on traffic.
And how big of a high school did you go to?
There were 2,000 people altogether.
Okay, so 500 per class.
Yeah.
A big school.
Large school, yeah.
What was your claim to fame in high school?
Okay, well, I don't know if that I had a claim to fame, but I was an athlete.
Okay. What was your sport?
Field hockey,
Oh, wow.
a little bit of track. Yeah, it was a field hockey.
And then what did you do when you graduated from high school?
Well, geez, what did I do? I started my college career at nearby Kent State.
Kent State, famous Kent State.
Yes, famous Kent State.
Yeah, for Dad in Ohio.
He has a good memory. Yeah. So I started there. My original major was French.
Really?
Yeah.
So
Yeah.
you took French in high school?
Oh, yeah.
Did you do a high school journey to France?
Unfortunately, I did not.
Oh, okay.
I would have enjoyed that, though.
So how many years of French did you take in high school?
3.
Okay.
Yeah.
So,
I actually took the 4th year off of French.
but then you decided you were going to go to Kent State and be a French major.
Yes.
What did you think you would do with it?
I thought I was going to be like a translator.
Okay.
I thought that'd be fun.
Then when did you switch majors?
I switched a couple years in. I got my associate's degree at Kent. And then I switched over when I went to Penn State, actually. So I transferred to Penn State and switched to psychology.
Okay.
Yeah. Did a lot of research there.
What prompted the switch?
Well, there was always an interest in psychology. I come from a very large family, and I'm the 7th of 8 kids. I have 5 older brothers, and it's probably enough that I probably don't need to say any more about that, right?
Okay.
So I've always found people to be very interesting, right? Not to kind of minimize my experience or anything that people went through, but I was always curious.
What makes people tick?
Exactly.
And how do they turn out the way they are?
And how to support them. So I started off at Penn State, psychology, research, heavy focus on that, got a little burned out on it. And so for grad.
And so let me ask about research. So it's like with mice or with what sort of research, or were you?
It was more social psychology.
Okay. So human subjects.
Human subjects.
So setting up these situations.
Yes. Yeah. So I mostly looked at like our biases, right, and body image.
Okay. So this was at Penn State.
Yeah.
And then
from there, I got my graduate degree. I moved to Florida and finished there.
Okay. And your graduate degree is to become a licensed mental health counselor.
That's right.
And does that come with like a master's degree?
That's a master's degree.
That is a master's degree. So what was training like in Florida to get your master's to become a mental health counselor?
So the program I went to was called, the school I went to was Asbury Seminary, right? So it was an accredited program that required like an extra year basically of religious courses. And the reason I chose that path was While I was doing research at Penn State, one of the many articles that came across was how more and more folks wanted to bring their spiritual concerns or questions into the counseling world, which was at that time not really practiced, not considered very ethical at times, right? How you approached it. So I wanted to be more comfortable with that, right? Not that I would ever assume to take the role or place of a priest or a minister or whatnot, but just be more informed about that area. So I enjoyed that extra year of religious courses. Those were probably my hardest classes. Actually,
I'm just curious, were your
Yeah.
religion courses
yeah.
like on the theology of Christianity?
Yes.
Was it a comparative religion? Did they want you to come out with a understanding also of Judaism, Islam, Hindu?
It was definitely geared more towards Christianity, although there was a component to consider all the other religions, but it was mostly focused on actually Methodism, because that's the school is based in Methodism. So that was a year of classes in mental health.
Tell me what it means to be a psychometrist.
Sure. Yeah. No one knows what that means.
No.
Yeah.
I kind of have a vague idea, but is that a credential? Is that part of your master's, or do you do that and so you are that because that's what you do?
Oh gosh, it depends on the state you live in.
Okay.
Yeah, it is one of those weird in between career paths for folks who like psychology. You don't have to have, in the state of Iowa, any kind of license or credential, although I am certified in it. I have gone through testing to pass it and all that good stuff. Some states,
you have a bachelor's degree
and a bachelor's and a master's, so I'm a little overqualified in Iowa.
Right.
But in some states like Ohio or Texas, for instance, you do have to have. There are more requirements for it.
And then tell us what it.
So what do they do?
What does a psychometrist do?
So psychometrists are usually working alongside psychologists, which are mental health professionals who have doctorate degrees, right? So psychologists or neuropsychologists, and you do testing for them. You'll do cognitive testing, neuropsychological testing for folks. Yeah.
So psychometry is really the act of administering and interpreting tests, or
well, that's the fine line. I would never say I interpret the test. That's the psychologist's job, but I do score and summarize the data for them.
So if I had somebody that had mild cognitive impairment, and I didn't know if this is mild cognitive impairment from chemo brain, is it early Alzheimer's disease? Is it related to lack of blood flow to the brain? I might send them to a neuropsych department, and that might start off with some testing.
Absolutely, yeah.
And you would be the one administering those tests.
Me or the psychologist, yeah.
Okay.
Yeah.
And
but if you were lucky, you would get me.
Yes. And is some of it written test, and some of it is like reading words and asking them to tell you, 10 minutes later what words you said.
Something like that, right? I can't tell you all the secrets, right?
Okay. Because then people would prepare at home for the test before they went in.
We don't want a practice effect here.
How long does an initial visit for psychometry take? How long is the patient there?
Well, for the testing portion, the part I would see them, it could range from an hour at the shortest to 2 hours plus.
Oh, wow.
Some folks it does take longer, if there's a language disorder going on, right? But usually prior to testing, you would meet with the psychologist for the interview, for a clinical interview. Yeah. And usually before you see a neuropsychologist, you would probably see a neurologist who referred you to us. Although that being said, we often get referrals from primary care as well.
Yeah. Do you know that it is very confusing for those of us who are referring patients with cognitive impairment, where to start?
Yeah.
And sometimes no matter which way I start, I'm told, no, go the other way. So let me just say there's 3 ways that I know of starting it. One is I could send them to a speech therapist who does some form of, I guess they don't call it psychometry, but they do some assessment, and then speech therapists, as you know better than I, do therapy, brain therapy.
Sure.
So that's one direction I could go. I could go to neurology, or I could go to neuropsychiatry.
Yes. Yeah.
What do you think is the proper first step for someone who has what I perceive, as an oncologist, as mild cognitive impairment?
Oh, I don't know if there's a wrong
Okay.
first step.
Okay.
If that helps, you could start with us.
And should I start with an MRI first?
We love it when patients come with
Blood
MRIs,
first.
blood work, just all that
stuff.
clinical notes.
Because as a cancer doctor, I'm the patients I'm seeing have cancer, so I always think, okay, could this be related to their cancer diagnosis in terms of brain metastases, or could it be related to their cancer treatment?
Sure.
Obviously, if somebody had brain radiation or somebody had chemo, those could cause cognitive, or someone can have cancer and Alzheimer's disease at the same time.
They sure could.
Or any of the other
or
causes.
Anxiety too, right?
Yes,
and that can affect your attention and look like memory issues. Yeah.
So the relationship, your job position, and being a psychometrist and a counselor, is was that something you sought out, or that was part of the job description?
That's a good question. So no, it's a short answer. I actually started doing psychometry in Florida prior to going to grad school because I thought it was a good connection between my research experience in psychology. It was before I knew I wanted to become a counselor. But I was so burned out from research, and I felt like psychometry was just far enough away, right? So I really enjoyed it. I started here at Mercy, a few years ago as just a psychometrist. And then we developed the clinic, the treatment part under our clinic about a year ago. It's almost been a year. So yeah.
Okay.
Yeah.
So you started off as a psychometrist, and then while being there, you've brought the counseling into your department. And are you kind of like a division in the department of neurology? Or?
So neuropsychology and neurology are different departments, but we're under the neurosciences.
Neurosciences, okay.
And I'm under that too.
Gotcha.
Yeah.
What aspect of counseling really excited you to pursue and get your master's in counseling?
Yeah. Well, I think it goes back to that original desire to understand people more, right? Research it satisfied that to a degree, and then the expectations of constantly turning out research just became it got distracting, right? Kind of took away from my interest. And it also I know a lot of folks, there's a lot of creativity for them in research, but it didn't satisfy that for me, right? And I just find a lot of creativity in treating folks as well. Yeah.
And I don't want to put words in your mouth, but I would think that, being a psychometrist and sort of being part of that diagnosing of what's wrong, but you're not actually being part of, let's help the person.
Sure, exactly.
Heal, be better. And obviously counseling is all about that. Not just figuring out what's wrong, but to help someone be in a healthier state.
Yes. Yeah, that's right. Yeah.
Okay. So we're talking now about optimizing mental health. I've always been fascinated by the fact that, when you say the word health by itself, most people, I think of a positive thing. And when you say physical health, I think of someone vibrant. When you say mental health, you think of the negative aspect, and you don't usually talk about typically mental health unless you're in a positive psychology department. Usually mental health is brought up in the terms of people who are lacking in good mental health.
Sure.
So
even though that's not true, right?
even that's
Like
not true.
you have
And
mental
maybe-
health right now in action,
we,
right?
we all have mental
Yes.
health,
Yes.
but yet we tend to associate mental health with a
Mhm.
disorder as opposed to
Mhm.
a state of positive being,
Mhm.
which is maybe part of the stigma and why
Certainly.
mental health in terms of trying to get parity with, paying for treatments of mental health has
Yeah.
been much more of a struggle than paying for what we call physical health. But yet
Sure.
we know that
It's connected.
it's all
Mhm.
physical.
Yeah.
Yes, brain and
Chemically
this
based
idea
and
of
yeah.
even our personality.
Yes.
So what's your thought,
Oh boy.
having been a researcher, a psychologist, a psychometrist, like the reason why people have different personalities?
Oh, come on.
Oh, come on, I should know that? or that would be a 3-hour answer.
Okay, wait, are you ready for my answer?
Yeah.
Tell me what you think.
So I think it's a combination of nature and nurture.
He literally took the words out of my mouth. I don't even know why I'm here.
But I guess, do you think it's more nature or nurture?
Oh,
So,
goodness.
I mean,
yeah.
Trisomy 21, we think is more nature than nurture.
Sure.
Okay.
Sure.
I don't know.
That's tough. That is really tough to answer.
Yes.
I tend to agree with you. Even in my approach in treatment, right? It's not always super important for us to figure out, why am I experiencing this constant dread? Why am I constantly worrying? I don't normally behave this way, right? Sometimes initially at treatment, we'll just start on let's attack the symptoms, right? First, let's get you a little more level feeling, a little closer to your baseline. And then if you're interested, we would travel a little more in the past to make those connections if that's something someone's interested in.
Yeah. I totally understand that. It probably doesn't matter. You might be curious about it.
Sure.
And there was a time where, not in Iowa, but, in New York City, where if you were anybody, you had your own analyst trying to help you figure out the reason you are what you are.
Right. That would be like psychodynamic theory. And that kind of treatment tended to last years and years and years, right? Whereas the kind of treatment I tend to provide is considered brief counseling. And brief meaning anywhere from 3 months, 6 months. And I include up to a year, although some people would say that's not considered brief. But I don't, I'm a little more flexible.
So as a mental health counselor, master's psychometrist, you're obviously not able to prescribe medications.
No.
That's not the route you take. Would you say, what would you describe as your technique? I mean, is it cognitive behavior modification? Is that sort of the umbrella of what you do? Are there other terms that better describe the type of counseling and how you get someone from the state of dissatisfaction and unease to a healthier mental state?
It's a really good question. And I'll start with, it's always important for me to make a connection with a person, right away. So we call that like the rapport, the therapeutic alliance. And I don't have to have, I don't have to root for the same football team as them to make that connection. So as long as it's an authentic connection, and if it doesn't work for whatever reason, that doesn't offend me. I always tell folks when they meet with me, if this doesn't work out, if you're uncomfortable for whatever reason, it won't hurt my feelings. I have those 5 older brothers, right? So I no longer have feelings. That's okay. I will actually help you find someone else. That is what I care about.
Yeah, that's a good point. The therapeutic relationship is huge.
Huge. And actually tons of research, and you probably know this, but tons of research, and it's been replicated zillions of times, that the therapeutic relationship takes up the largest amount of variance of explaining change in a person.
So that's the essence of the healing.
That's the magic.
That's the magic. And I totally understand that because, I'm not trained in mental health counseling, but every patient I meet the first thing I do is establish a
Yeah.
rapport,
Mhm.
and the therapeutic relationship is healing in and of itself.
Yes.
I don't really know how to do cognitive behavior modification. I'm aware of it, but I can tell you just being present and
Yeah.
having that relationship
Yeah.
often leads a patient to say, I just feel so much better, which is what
Yes.
the goal is.
Doesn't that make you feel good too? As a provider, you're like, I'm so glad.
It
that
and you
have
don't
that.
actually have to be a provider. You can
Right.
actually be a checker in a grocery
Yes,
store, and
right.
you could have a
Getting your hair cut, right, ladies?
a
Yeah.
10-minute or
Yeah.
a 10-minute relationship that can
Yes.
actually have some therapy benefits.
Someone's listening to you.
Yeah.
Mhm.
So that's a good
Yeah.
point.
The
So that's
lost
number
art of
one.
listening.
Number one, the
Mhm.
therapeutic relationship.
Yeah.
And then let's just use as an example anxiety, distress over fear that the cancer is going to come back. So you've just had your last treatment of 6 months of chemotherapy and you've been discharged from the clinic, you're cancer free.
Hooray.
And you've got this feeling in the pit of your stomach that, gosh, and I just can't let go of that thought.
Yeah.
What it comes back, and I'm not going to see my kids graduate. I'm not going to be at the wedding. I'm not going to.
Yeah. Yeah. So after developing some kind of rapport with a client, then I want to measure through our conversation, whether directly or indirectly, their motivation. Right? What is their motivation for change? Are they still kind of stuck at, I don't think I have a problem? Because some people do come to therapy believing maybe because my wife made me come here, that kind of a thing. But most of the folks in our clinic are very motivated for therapy. So we'll kind of fast forward past that. The approaches I take, cognitive behavioral therapy, and I use acceptance and commitment therapy a lot together. They complement each other. So the person you're talking about, that fear of resurgence, they're very much usually thinking about the future only, and they're kind of disconnected from their present usually, right? And I like to help people find a balance in that. You should not ignore your future, obviously. It's important to plan, but finding that moderation and being able to enjoy what you have, that time you have now, right? I read a quote recently and I kind of wrote it down, and it's about, where is it here? I wrote it down. So that struggle to escape pain, right, is usually where we end up suffering, not from the pain itself, right? And I kind of love that because we're meant to experience pain. It's normal to have fear of resurgence, right, of the cancer. That's not unusual, but the struggle to avoid it or the struggle to not have any pain, that's kind of where we start seeing a little abnormal or
a couple of things to respond. One of the things you said, it's okay to plan, but you don't want to live in the future. So some wise person years ago, there's this quotation that the twin thieves of happiness are regrets of yesterday and worry about tomorrow. That if you can be in the here and now, we have everything we need this second where we're here together for perfect joy. There's nothing we're missing. It's when we think, who dissed us earlier today? What's going to happen tomorrow? That we start to worry. And it's healthy to maybe reflect on yesterday, journal. It's healthy to plan for tomorrow. But when your mind gets captured and you just start perseverating and can't let go of this, missing your graduation in the future, missing the so bringing it to the here and now is one therapeutic technique.
Yeah. So practicing different mindfulness techniques, right? Mindfulness curiosity. One thing I always emphasize is, and if anyone's watching who's a client of mine, I'm sure they've heard me say this a zillion times, but I never want you to ignore that thought or the feelings associated with it. I want you to acknowledge it and decide what to do with it. move on, right? Or is there an action you need, an appropriate action to take, right? And whatnot. Is no reason to suppress it. It's normal to be nervous about the cancer coming back. Yeah.
I'm curious about the word anxiety, and then
Mm.
sometimes those of us who don't really know how to say anxiety/depression, because
Mhm.
people are blue because they're worried all the time. And so is that anxiety, is that depression?
Mhm.
But this thought that anxiety is just our body's way to express that we have there's a fear in front of us.
Mhm.
So I want you to challenge me on this, but my thought is that fear is not a bad thing. Fear is your body telling you, hey, pay attention. I recognize a danger here that
Mhm.
requires my attention in order to mitigate the danger and move forward. I
Exactly.
mean, as you're climbing a mountain and you come to a place where you have to step over 2
Mhm.
feet and it's 1,000-foot fall, having fear is a good natural
Yes.
thing.
Yes.
And it's going to say, stop trying to do 3 things at once. This is an important step.
Yes.
Pay attention, move forward. Fear is a good thing. It makes you. Is there a point at which
Mhm.
people who say, I'm anxious,
Sure.
that they're worried about something that is practical, and that you deal with what is the cause of that anxiety and
Mhm.
as a problem to solve?
Sure. So when I think about anxiety for folks, I'm often listening to their words to figure out, is this more of an amygdala-based anxiety? Like you were just describing, that fight or flight, this
Mhm.
fear, which is normal, which is
Mhm.
good for us
Mhm.
most of the time. Or is this more of a prefrontal lobe kind of anxiety where I'm kind of creating, I'm manifesting by perseverating, by using my imagination to assume the worst, to catastrophize
I
and
see.
whatnot.
So you divide the
Mhm.
anxiety between those two. Yeah, the
So
amygdala, fight or flight, or
sure.
the prefrontal, which
Mhm.
is more that
Right.
creating the
Where
fantasy, future,
Mhm.
perseveration.
Right. Why that's helpful, to me at least, as I approach, it tells us where should we go with practical coping skills, or treatment, right? So if someone is really deep in that amygdala-based anxiety, that being said, amygdala is always involved in anxiety, but if that's where it's kind of stemming from,
Mhm.
we'll do more like breath work, kind of using our body to calm down the body
Mhm.
and mind,
Mhm.
right? I'm always talking about the connection with the between the mind and body. So whether that includes breath work or progressive muscle relaxation or any kind of stretching, we'll do it, right?
Mhm.
We'll talk about that.
Do you ever, is biofeedback come in there? Or is
You know, I'm not certified in that yet, but yeah,
okay.
there's a
you can
couple things on my
actually
list that, yeah,
you can
my
actually
to-do list.
lower your heart
Yes.
rate by
But
or
I've done this. It's not exactly biofeedback, but
okay.
where I was working with kids a lot in Florida, and we would do like push-ups. Yeah, I would try it too, and I'm not afraid to do that, right? With them, and that would get your heart racing,
Uh-huh.
right? All right, let's notice our heart racing, right?
Feel it.
And then, all right, let's use that hippy dippy breathing technique I told you about, right? And she would notice her heart rate going down, right? So that's just a way of
Uh-huh.
practice. It's not
Yeah.
exactly biofeedback,
Right.
but
Right.
you
A
could
way
use
of
like a heart rate
acknowledging and
monitor.
recognizing, because
Exactly.
the you step outside and a dog jumps and barks at you, doesn't
Sure.
touch you, but you feel
Yes.
the physiologic effects.
Mhm.
I would say the opposite, like you get a hug from somebody, there's a huge physiologic effect, but it isn't as obvious to
Mhm.
someone
Sure.
as that jolt of
Yeah, that adrenaline,
fight or
right?
flight. Yeah.
Unless it's someone you don't want hugging you, but yeah.
Yes, but I mean, what I'm saying is the positive effect.
Yes,
Even sitting in a therapeutic relationship for 10
Mhm.
minutes, there's changes in physiology, but we don't
Mhm.
recognize it as obviously as we do the opposite.
For sure, right?
effect.
So that brings up a point of taking the time, using mindfulness, like the grounding techniques. Maybe while we're doing breath work, we'll pair that with grounding techniques to focus more on.
Say more about, I don't know exactly
Yeah.
what you mean by grounding technique.
Grounding techniques is about becoming aware of the present, right?
Oh.
Using your five senses, because our
Okay.
brain uses those five senses, right? So I've heard to take in information, right? So when we're in anxiety, and this is another technique I would use if someone's in their fight or flight amygdala mode, let's get out of that and let's get in the present. So you might do, what do I see? So describing 5 things with that sense, 4 things you feel, right? And so that's grounding. You're bringing yourself to the present.
Okay.
Right. So you're settling yourself. So beyond amygdala-based anxiety, then you have the prefrontal cortex, like I mentioned, and that kind of anxiety is usually where I'll use a little more CBT focused cognitive behavioral therapy techniques where, we'll identify the thought to try to change behavior, right? To kind of change how you feel and just see that connection between your thinking, feeling, and behaviors. And read and use
Maybe
logic.
give an example of
Yeah. I'm rambling, aren't I?
No, you're not rambling. I think I know what you mean, but I think a concrete example of
Okay.
what would be the.
So Dr. Deming.
Yes.
Yeah.
I've got this prefrontal anxiety that is.
What are you worried about? Tell me.
I'm worried that I'm going to die and that I'm not going to get to climb that last mountain I want to climb, and that I'm not going to, I've got a grand niece that just turned 1, and I really kind of want to be at her wedding, and I'm just thinking that, it's just not going to happen.
Wow, that sounds like awful. You're gonna. That's just. So okay.
Yeah, I'm normally a happy guy, but I just can't stop thinking about that.
Yeah. All right. So when you're having these thoughts, what kind of feelings do they bring? What do you notice they bring up in you?
Oh, just almost like a grief.
Yeah.
Yeah, like a black veil.
Oh, wow. Yeah. What's that feeling though? What's the feeling attached to it? Feeling words are one word answer.
Loss.
Loss. Tell me more.
So to break the veil here, so this is what you're doing is cognitive behavior therapy. You're getting there.
We're getting there.
Okay.
He's having a hard time identifying his emotions.
Yeah. So I'm an actor right now, and I'm trying to think, what would I say? I just feel sad.
Sure.
I feel sad that this is something I thought I would experience in the future, and now I just see that it's probably not something I'm going to experience, and I feel, sadness.
Sure. Yeah. What do you find yourself doing when you're thinking about this and noticing this sadness and feeling this sadness? How does that affect you?
I would say time just goes by and I don't get anything done. I just am thinking about what I'm going to miss, and I just kind of wallow in my sadness.
Yeah. So you don't get anything accomplished.
Don't get anything accomplished, no.
And then let me guess, you start feeling bad about yourself because of that.
Yeah.
Kind of snowballs.
Yeah. And then, maybe I just open a bottle of wine and then go to sleep.
Sure. So you're talking about avoidance in a sense, right?
So I don't have to think about it.
Exactly. And how is that helping?
Well, I'm here because, I was told I don't seem to be doing well.
Right? So what I was trying to connect here was using that triangle, what we call like the CBT, the cognitive triangle, making the connection between what you were thinking, what you were constantly thinking about, how it was making you feel, how that was affecting your decisions, your behavior, right? And I'm on the spot, so I was a little nervous, to be honest. But from there, we would eventually get to a point where these kind of thoughts, where they're perseverating, we would start challenging any, maybe not in the example you gave me, but oftentimes when someone might say, I see a lot of people with Parkinson's, and they think, they think differently of me now because I have Parkinson's. Even though they don't know I have Parkinson's, they're noticing the changes in me. So using CBT, after going through the triangle with that person, I would then challenge that thought. Like, what's the supportive evidence to support that thought? And what's the evidence that does not support that thought? In a gentle way, right? Of course. And we would walk through that, right? And you start noticing the idea, especially with CBT, is that you would start noticing these patterns of thinking, which are usually very much ingrained even prior to these diagnoses. So prior to cancer, prior to Parkinson's, it's just when these crises come up, they tend to kind of flash a light on these thinking errors, right, that are popping up and showing, affecting their lives.
So you basically gently show them their thinking errors, that that they're the premise on which they're basing everything is not true, or
not accurate.
Not accurate.
Yeah, but the feelings that come from those thinking patterns are very much true. They're very much real. All right, that's where the suffering is really manifest, right? And then if I'm wallowing, like you were saying, how did that affect my behavior? Maybe drinking, avoiding, sleeping, right? So you see that connection. That's what CBT does a good job of, making that connection, highlighting it, creating awareness, insight. So then it can be very empowering once you have that information. Then you can choose to make it change, right? And that's where therapy is hardest. It is hard to show up to that therapy appointment, but it's even harder afterwards to change that thinking pattern, to make that effort. Yeah.
Is that a bit of a habit? So, for example, everybody learns how to brush their teeth as a kid, and most people through life up to death do that, brush my teeth at least once a day. They maintain that. Those people who know that physical activity, exercise is important, might do it for a while. It's a habit, and once it gets to be a habit, they do it, but then they stop doing it for some reason, and then the habit is not doing it, and so then you need to get back into the habit. Are there techniques that are helping with anxiety or other issues that are just like forcing or encouraging a new habit to happen, that breaks the old habit of just sitting there wallowing in your perseveration?
One thing I would say that CBT and ACT, or the acceptance and commitment therapy, have in common. They have many things in common, but the one I want to focus on to answer your question is they both focus on a person's value system. What is meaningful to you? What are your values? So if I need to reestablish a habit or start a new habit, you're not going to do well if you're like, I just need to do this. I'm going to will myself through it. Typically, people don't do well in that regards. But when you connect that behavior and thinking to a value of importance to a person, they are way more likely to succeed and continue if they backslide, if you will. Yeah. So the first thing, new client paperwork that I have, people will see on there, what are your values? What are your strengths? What do you enjoy doing? Because we want to use those authentic and very, natural talents in our work together. So I'm always asking about that. Yeah, we want to use that natural motivation. Yeah.
Let's talk a little bit more about optimizing mental health in cancer patients. In your experience, what are some of the issues that interfere with optimal mental health in patients that are either just been diagnosed with cancer or in the middle of treatment, or are done with treatment and are cancer-free, or those that are living with an incurable cancer?
Sure. So just like a lot of the folks, neurology has been studying me all this time, who have Parkinson's disease and whatnot. The systems in a person's life, when I say systems, I mean community, family, right? Your occupation. Those are where our stressors tend to come from, right? So I look at where in those circles and those systems are there some pain points for that person, right? And it's individually experience for each person. So I look at their environment, right? Where's your support? That's one of the first things we'll explore is what's your support system. A lot of research tells us that the better a support system a person has, that they tend to do better that way overall, whether it's mental health or cancer health or whatever kind of health. Yeah. So we'll start there. Yeah.
With the idea that you might encourage them to reinforce those, to utilize those supports.
Yes, exactly. And then from there, again, it's about empowering the person, right, to be able to help themselves as well, using the tools available to them or that we'll learn in counseling together to reach more of their baseline. Yeah.
And you obviously would see similarities in some of the issues that the various chronic diseases, regardless of what chronic disease it is. You just had a heart attack, you've got cardiovascular disease, and your parents died young of that, or you've got Parkinson's disease, which is treatable but not curable. And there's many other chronic diseases like cancer that you can't always just get rid of it.
Right. About managing. Right. And the same is
living
true
with cancer.
Sure. Yeah. Managing it, living with it, just like for some folks, that's how it is with depression, anxiety, bipolar, diabetes, right? Yeah. So finding a way to have your identity, to enjoy your life, be present, take it on, like as much as you can, modify if you need to, right? And coming to terms with that, accepting that. Yeah.
So the next question is not cancer specific, but when do you think, what are sort of red flags for individuals that might mean that they could benefit by seeing a therapist or counselor?
Well, first I would say certainly someone who doesn't have as many supports, right, in their life. If someone's having a hard time functioning in their life, right? So if they're noticing that their worry, no matter where it's based, is getting in the way of working, focusing at work, if they're becoming more irritable, and then that's getting in the way of work, right? So you'll see these symptoms manifest some way in a behavior, right? And it's interfering somewhere. Is it in your work life? Is it in your home life, in your relationship? Those are usually those red flags, right? That maybe I need some help figuring this out, right? Then there are some more serious red flags, such as thoughts of wanting to hurt yourself, right? Thoughts of, and we all, have, there's the language that we have, like, oh, I just wish I was dead, right? And it's not even like meant in a way seriously, right? But when these kind of thoughts, we're actually kind of mean it, we find ourselves meaning like, gosh, I wish I didn't wake up tomorrow, and it doesn't actually even go away after you think that, and you have it over and over. Probably a good idea to see somebody, because that's burdensome for that person. They're suffering. Yeah.
And so we're coming up to the holidays. What are some of the triggers or maybe things to look out for as we approach the holidays, as it relates to either optimizing mental health or avoiding situations that might worsen our mental health?
So I know you want me to say family, right? Yeah. No. Okay. Kidding, right? Hi, Jaden. Hi, Tyler. No, I love those guys.
Are you going to see your brothers for Thanksgiving?
Unfortunately, no. Yeah.
Did you say fortunately no?
No.
Okay, so family is one trigger.
Sometimes family can be triggers.
Should you prepare yourself?
Oh, yes.
For So is one strategy just like, I'm just not going to say anything? I'm just going to
So we call that filtering. Yes.
just
Right.
gonna
Boundaries.
let
yeah.
them talk about,
Mhm.
and I'm just not going to respond.
Sure, absolutely. And if you can remove yourself, go to a different part of the house. If maybe
Right.
the rest of the family's watching TV, maybe
Or-
I'll join
or
them
you
there.
just skip the whole
Or if it's really
thing.
that toxic,
Mm.
I mean, it's different for everybody, of course, but yeah. And then alcohol, drug use, those kind of things can absolutely not optimize your mental health. I know sometimes folks will report to you like, well, or to me, well, I do feel better though after I smoke that or drink that. And like maybe in the short term, that might be the case. Long term, though, it's doing more harm than good. And it's really it's covering up a symptom and whatnot. So, yeah.
Okay.
Yeah.
So we're going to open up to questions. But before we do,
Mhm.
anything that I haven't asked you that you want to share with the group before we open it up to questions?
Not that I can think of.
Okay.
Yeah.
Okay. Well, we've got a live studio audience here that we'll let them ask first. If you're watching us live streaming right now and you have a question, please just put your question in the comment section of the software that you're using to watch us, and we'll open up to questions. Poon, do you have a question?
Yes. Often I see friends post on Facebook that they're going to have a scan tomorrow. They're 6 months or yearly, and they are just stressed. Any short answer or short you have for them?
Scanxiety, any self-help things you can do, because you're doing just fine, but now I've got the scan scheduled.
Right.
It's the day of the scan or the day the night before.
Well, if they don't already have your face on the wall to throw a dart at, that would be number one. No, I'm just kidding. That's not your fault that they have a scan. No, I mean, honestly, self-care, right? Whatever that means for that person, and reassuring yourself with the facts, right? So that kind of anxiety is mostly based out of the prefrontal cortex. So it's going to be very imaginative, right? Worst case scenario, let's stick with the facts, what we know. Let's not try to predict the future, right? That sort of a thing. Yeah. I mean, again, like we kind of said earlier, the fact that there's fear is okay. It's okay. Yeah.
It's natural.
It's natural.
That's
That's your brain working
it's
normally.
natural.
Yeah.
That's the way it works. And it's sort of evolutionary. We have been programmed to look out for bad things and to be more sure that a bad thing's going to happen than a good thing.
Yeah. Good question.
Okay. Tim.
Yeah, so I got a question. I think it's a good one. So
we'll be the judge of that.
Yeah, okay. Well, I'll keep my fingers crossed on this one, right? So I noticed when you were interviewing Dr. Deming and trying to get information out of them, one of your tools, big tools, is the communication effort of saying, okay, what do you feel? It's like cause and effect type of thing.
Sure.
But now you come across a person who just has that block that you just can't get through. Is one of your tools to say, all right, I'm going to try hypnosis. Do you use hypnosis in your practice?
No.
What do you think of hypnosis? What do you know about hypnosis?
To be fair, well, to be fair, I don't know much about it.
Okay.
I'm not trained in it. I know folks are trained in it. A little bit I would know. I would say it was more popular several decades ago. But it's still used today. I don't know much about it, honestly. Yeah. From my understanding, it's and this is very, very bare bones, but from my understanding, and you might know more, but you're getting someone to a very relaxed state where they're okay with being so vulnerable and opening up about stuff. But don't quote me on that. Yeah.
Yeah.
If it's helpful, then use it. That's what I would say. Yeah.
Yeah,
if it's not causing harm.
I'm skeptical.
Yeah,
especially when it gets into it becomes a form of entertainment and nightclubs and it's just like okay.
I didn't want to say that, but yeah.
But I don't know about it. So if
it's not causing harm, I would.
There we go.
Yeah. Good
Here we go.
question.
Angelina.
Hi. When we talk about depression, sometimes medication
Mm-hmm.
can bring on either anxiety or both with depression.
Mm-hmm.
How do you help clients with that? Because part to the doctor could change the medication,
Mm-hmm.
but say like hormone therapies for cancer survivors that have to take these, but they're all going to have those same. So you're already given this. There's studies that show you could be affected, but we don't know. It varies from people to people. But how do you gauge that to helping a client out if they're
Yeah.
thinking, well, I'm feeling anxious, kind of anxious that I wish the doctor didn't tell me that because I don't like to Google things myself.
Yeah.
Yeah.
But how do you gauge that if in determining whether you are going through certain depression by the medication?
And along with anxiety, depression, sort of emotional lability, it
Mhm.
can be a common thing
Yes.
in either women with anti-estrogens or men with anti-testosterone
Mhm.
medication.
That's a good question. So that conversation can go a lot of different ways. So usually my role would be partly education, and the other part would be helping them communicate with their provider, especially if they're nervous about that, because sometimes we're afraid to tell our doctors, like, this is actually not helping. So in terms of medication for mental health reasons, one of the things that's available to us is GeneSight. Have you heard of GeneSight?
No.
So it is this wonderful tool that takes your, you take a swab or DNA to see what psychiatric medications will work best for you. So I know, right?
And is that for anxiety or depression or other?
All of the above?
Really?
Yes.
So some people's genetic makeup predisposes them to have a more favorable or beneficial reaction to certain classes of drugs.
Absolutely.
Okay.
Yeah. It's really amazing. I know, game changer, right? And it gets a lot of detail. It's a beautiful report. So that's if they haven't done that already, I would encourage them to go through with that. And your even Mercy primary care doctors can
order that.
Oh. I know.
Did not know that.
Because that dance of, hey, is this medication going to numb me out? I don't want to be a zombie. Is it creating more anxiety or suicidal thoughts? That's exhausting for folks, understandably. And if you're going through cancer, you don't need that.
Tell me again the name of that test.
GeneSight is the name of the company.
GeneSight.
Yeah.
GeneSite.
SIGHT.
SIGHT, like insight. I see. GeneSight.
You like that?
SIGHT.
Yeah.
There we go. Okay, thank you.
Yeah.
Kevin.
You mentioned, used the word wallowing at one point.
Yeah.
And people wallow in different places, but one place everybody wallows in at some point is grief.
Yes.
But is it at one point? Where is there a blockage rather than just wallowing? It's very comfortable wallowing there, but it's not something you get over. Or if you had a blockage, and what kind of techniques do you use to, like I say, move through, move on?
Sure. Oof, that's a really tough question, and we should schedule a session. No, I'm just kidding.
Yeah.
So there should be room for wallow or sorrows, whatever you want to call it. There's room for that, and there should be room for that, and it's different for everybody. So you might go through a period where it's longer than what my period would be, and
timelines are different.
Exactly. And I would always go back to, well, is this causing problems in your functioning? Are you able to engage with others? Are you able to take care of yourself, brush your teeth, take a shower, work, whatever your functioning looks like, right? That being said, just because you're, let's say you're done with your wallowing, and you're not actually done, right? You might have periods of going back and feeling sadness, and there's nothing wrong with that. There's nothing wrong with that. Did I answer that question completely?
So I was with a patient today who's been a widow for 2 years.
Sure.
And when she is out and about with friends or engaging, and she can enjoy herself, but when she's alone, the thoughts of what she's missing by not having a partner become, lead to tears. And concerned that maybe she's not doing as well as she appears to be doing when she's in public.
So grief work isn't about going through a stage, right? We usually think of it that way because it's always taught that way. What stage of grief are you in, right? Like, it's not something to ever be completed. It's an ongoing thing. It's a change in the relationship too, right? I always think of it as a relationship with that person didn't change, or it didn't completely end. It has changed, right? So there will be a vacillation between more focused on the present and my responsibilities, and then a switch to focus on the grief work, right? The reminiscing, the tears, usually what we consider healthy is kind of a back and forth, right? So there's no wrong or right. There's no stage per se, although they can be helpful descriptors, right? These different stages.
Right.
Yeah.
I sort of see, just over time, what is always bittersweet becomes a bit more sweet and less bitter, and that you are not isolating yourself to wallow in that grief, but that you at times have moments where you remember in a way that brings a tear.
Yeah.
And sometimes those tears are not actually misery, they're just kind of this ennui sort of I mean, you can have tears over the happy times.
Yes,
too.
Absolutely.
So,
yeah.
Well, we have run out of time. Do you have one more question?
Yeah, a viewer on
a viewer one. Okay, yes,
on-
we do want to get to our viewers.
from YouTube, Ms. Gillmor. Really appreciate your breaking down the process. Can you tell us 1 or 2 tips that you found useful for helping family members who are struggling and are resistant to seeking help?
Oof. All right. So it depends, I think, on answering that question. Who is my client, right? If it's my client who's in recovery from cancer and they want to bring their family member in, that's one approach versus
let's just give a concrete, and this is what I'm interpreting, might be wrong, that the cancer patient feels that the spouse is struggling with this dynamic of what they're going through, and that the cancer patient feels that the spouse would benefit by seeing a counselor, but the spouse doesn't want to see a counselor.
Yeah.
What are approaches that the cancer patient can do to try to help the spouse that needs some help?
Sure. Oof. Well, if they're not coming into the session, I would talk to the cancer patient more to discover what is the communication like at home? What is the current dynamic? What is it about that dynamic that you want changed, right? What is the other person's awareness of that dynamic? What does it bring out in the two of you? Is this normal? Is it what you think is healthy between your relationship? And just start with what that person's comfortable with talking about, right? No pressure, no demands, essentially, just exploring, more of an exploratory approach and attitude. Yeah. I don't know. It's hard to answer questions like that.
And you don't want to be a stereotypical, but a lot of times, men aren't as prone to want to talk about it. And so there's nothing wrong. Well, you don't seem to be talking about, well, I don't have anything to say.
Yeah.
And, it's a difficult situation. I think love and compassion and understanding. And I think it just seems like there's something that isn't the same. And I benefited by seeing a counselor, maybe you would benefit by seeing a counselor. So, unfortunately, at our cancer center, we do have counselors, like Katherine, who sees the patients, but we also have a caregiver counselor. So we do have counselors that are separate and distinct that see the caregivers, because they may have issues that they don't want to burden the cancer patient with. They feel like this is my problems are so much less than hers. I don't want to deal with them.
Right. That happens a lot.
Yeah.
And from the patient's
Both
point
ways.
of view.
So they're both
yes.
wanting to help the
Right.
other, but they don't want to burden them with their own problems. But yet
Yes.
the essence of a relationship in marriage is that you help
It's
people.
a
through their
sharing.
problems.
Yeah.
Well,
Good
we are out of
question.
time, Catherine. We're going to have you back. If any of you watching the show know someone who would benefit by watching it, it will be available for anyone to watch on demand beginning tomorrow at the Above and Beyond Cancer YouTube channel and also the Mercy Cancer Center website. I hope you'll join us again next week. Thanks, Catherine.
Thank you.